Good afternoon, and welcome to today's webinar, COVID-19, How Much Do You Really Know? This event is brought to you by the John Wayne Cancer Institute at Providence St. John's Health Center and St. John's Physicians Partners. I'm your moderator, Lily Clark. Thank you for joining us today. With the novel coronavirus pandemic among us, our cancer experts have pivoted to join the fight to find safe and effective treatment for COVID-19. In today's webinar, viewers have the exclusive opportunity to hear from frontline medical experts about COVID-19 updates, including ICU management, antibody testing, immunology, and treatment options. And now I'm excited to introduce today's presenters. First up, we have Dr. Stephen O'Day, who is the Executive Director of the John Wayne Cancer Institute and Cancer Clinic, and the Regional Director of Clinical Research and a Professor of Medical Oncology. We have also Dr. Therese Hammond, who is the Medical Director of the CCU and ICU. We have Dr. David Krasny, who is the Medical Director of the Pathology Department and Laboratory, and Dr. Trayvon Fisher, who is the Assistant Professor of Surgical Oncology and the Assistant Program Director of Complex Surgical Oncology Fellowship. We have a very smart bunch with us. Now, without further ado, please welcome our first speaker, Dr. O'Day, who gives us an overview to discuss the immunology of the virus.
Thank you, Lily, and welcome everyone to this webinar. I am privileged to lead a group of highly dedicated physicians who are leading the effort at St. John's, Providence, John Wayne Cancer Institute in the COVID battle. We are clearly in an epidemic, and in the last 8 to 9 months, we actually have learned a tremendous amount. And I'm going to give an overview of that and then really hand it off to my colleagues who are going to really flesh out some of the details that I speak about. But first and foremost, we know a lot. And we need to know what we know and embrace it. So let's just first talk about what this virus is. This is what's called a coronavirus. It's a new variant of this virus that is very common cold and other viruses, SARS and MERS, some other viruses that are coronaviruses. So this is an RNA virus that is very contagious. Now, being contagious means there are different ways viruses can be contagious. There's what's called aerosolized. That means small particles can travel through the air and infect others. You can have droplets where it's more related to your secretions, and you could actually have contact through surfaces through droplets. And this is what we would call a highly contagious virus. The most contagious aerosolized virus, or one of the most, is measles. And just being in the same room with someone, even at a distance for a short exposure, you can contract measles. And then influenza is another virus that's much more of a droplet contact type spread of disease. So coronavirus 19 is really an aerosolized virus, not as contagious as measles, but we know that it can be through droplets as well as aerosolized particles, particularly if you're in close contact for a relatively extended period of time. It doesn't mean you're just going to walk in for 2 seconds and get exposed. So the amount of virus you receive over time is important, as well as the proximity in an aerosolized virus. And so that's where we are. That's why it's really critical that masks be worn, that we social distance and wash our hands. These are the primary ways we prevent the spread of this virus. Now, other speakers will talk about the treatment and how we're evolving. But what we really have learned recently is that much of this virus is spread without patients ever or individuals ever getting sick, or what we call asymptomatic spread. Particularly in younger people with robust immune systems, we've learned in recent months that maybe up to 40% of people will be contagious, but actually never get a symptom. And then maybe another 60% of patients will get symptoms related to their disease. And most of those patients will have a relatively significant viral illness that lasts 1 to 2 weeks, but they recover fully and don't need to be hospitalized. But there is a subgroup, maybe approximately 15 or 20% of patients who actually get sick from the virus, who can get very, very sick, and they have to be hospitalized. And the way we've approached those patients has evolved, and Dr. Hammond will talk more about that. But we are doing much better at treating sick patients. The science and the collaborative nature of the teams that we have brought together at St. John's. That includes our critical care colleagues, our infectious disease colleagues, our pathology colleagues, and our oncology colleagues, because in oncology, we have studied how the immune system affects cancer, and that's actually really, really helpful. So once you get into the hospital now, we understand that maybe putting you on a ventilator is the last option, not the first option. The other is we have an antiviral called remdesivir that through clinical trials that we and others have participated in will shorten your course and may get you out of the hospital much quicker than if you didn't have access to that. And then we also know that steroids, very common medicines we use for a number of different things that reduce inflammation in sick hospitalized patients, also reduce the mortality. So we, with a number of just straightforward learning how to treat this disease in the ICU, on the hospital floor, with remdesivir and with steroids, the mortality has dropped significantly, which is huge. There are still risk groups, and I think Dr. Hammond's going to talk about those. People with older patients with other diseases, obesity, diabetes, these are all things that can make you sicker with this virus. But the important thing is we understand this. The immune system does a very good job in most patients who contract this virus. Either they don't get symptoms or they may have mild to moderate symptoms but don't need to be hospitalized. But there is this cohort that is much sicker and that has a risk of death, and we are doing better at that. Now that we've made these successful approaches in the hospital and we're reducing mortality through our clinical trials and our research, we're really focusing in our research, and Dr. Fisher, I think, will speak about this, but we're focusing on patients who are not in the hospital but are developing symptoms, particularly if you're a high-risk group for having more severe complications. We have a new spike antibody trial with one dose of this neutralizing antibodies, and hopefully this is going to help us prevent high-risk patients from getting so sick that they even need to be at the hospital. And that's really going to be a huge bridge for us until the vaccines come on board. And I really think we're 6 to 12 months from an effective vaccine, but the science is moving tremendously forward. So that's the overview. And I also want to just comment on testing, and Dr. Krasny is going to speak about this. But when you have dramatic community spread of a virus, tracing and testing does not make sense. We have to assume everyone is contagious, and that's why social distancing, hand washing, and wearing masks are tremendously effective. We know this because when we do it, we can see the rates drop dramatically within a community. Where testing is really helpful, and there's two types of testing. It's called antigen or PCR testing. That's testing of the virus itself. And then there's what's called antibody testing, and that's the immune response. Antibody testing is very complicated, and the bottom line is it's not really helpful to the individual person, whether you've had an antibody test or not, and positive, negative. But knowing whether you have active virus through the antigen or PCR testing is important. But it's mostly important when we can get rates well below 1% in a community and then follow and trace and test outbreaks. That's how you contain a virus. But testing, mass testing, when there's 5, 10, 20% prevalence within a community makes no sense. And it's just spinning our wheels. So once we get things down really well with social distancing, masking, so like where New York is right now and others in the bubbles of athletics, in those situations, then testing and tracing is very helpful to keeping small outbreaks limited and keeping the disease from reacclimating into the community. But one of the confusions has been that once you have high prevalence in the community, that we need to be mass testing, and that's just not the case. So those are the overview. I'm going to leave it now to a very talented team of my colleagues who are going to talk in more detail. But I want people to understand that we have pivoted at St. John's. We've built an incredible team. In fact, I think this is one of the best places in the world to get treated if you need to from COVID. And it's because we have world's experts working together across diseases. We have access to community trials. We have adequate testing. We can get results. And we have learned a tremendous amount in the last 8 to 9 months. It's just not true. In fact, it is extraordinary how much we've learned about this virus. And kudos to the medical research community. And we have been part of that here at St. John's in moving the disease, following the science, understanding and adapting what we're doing in real time, day by day. And that has dropped absolute mortality in the hospital. And now I think we're going to pivot and hopefully prevent patients from needing to be hospitalized by even earlier interventions. So I'll stop there and hand it over to my colleagues, and then we'll happy to have questions at the end. Thank you.
Thank you, Dr. O'Day. Next, I'd like to welcome our next speaker, Dr. Hammond, who's going to cover how care management has changed as a result of treating those hospitalized with the disease. Dr. Hammond, the floor is yours.
Thank you so much, Lily, and thank you, Steve, for that wonderful introduction. And thank you to our participants for allowing me to be a part of this really important conversation. So over the next 10 minutes or so, I'd like to touch on a few different topics. I'd like to talk to you about the risk factors for hospitalization, specifically about intensive care unit admission and death. I'd like to give you a little bit of an update about COVID treatments, and each of the individual speakers are going to say a little bit about this. So some of this will be a bit repetitive. And then I want to sort of start the conversation about what happens after. Where do you go from here? Because as more and more people recover from COVID, we're starting to find out that there are some lingering side effects and effects from it. So those are sort of the broad categories. Now, in terms of risk factors, there are 3 different components that we have to look at: the pathogen itself, or the bacteria, or in this case, virus, the host, or the person who's infected, or the being that's infected, and then the environment. So let's talk about SARS-CoV-2, which is the virus that causes COVID-19 pneumonia and COVID disease. So as Dr. O'Day said, SARS-CoV-2 is an RNA virus. It actually uses a receptor on its spike protein to get into cells through this angiotensin converting enzyme 2 receptor. And so it's very wily in that way. As Dr. O'Day said, this is a relative of some other viruses, and it's quite special in that it can pass not only from droplet, but also directly through transmission via particles that are suspended in the air. So it's airborne as well. Now, the symptoms of COVID-19 are pretty common. The ones that get you into the hospital, by and large, are the 3 top ones: fever, cough, and shortness of breath, with fever being absolutely the most common presenting complaint to people that show up in our emergency department, or people that are ultimately diagnosed with COVID-19. About 80% of people have it. The incubation period, so once you're exposed to COVID, the incubation period can be up to 14 days. But in general, most people start to feel symptoms, if they're going to feel symptoms, in 4 to 5 days. About almost 98% of people will have symptoms by about the 11th day of exposure. So 14 days has been sort of set as a safe period of time after exposure, and that's why we advise people to self-isolate. Now, as Dr. O'Day said, 80% of people, by and large, will be either mildly symptomatic or non-symptomatic. They'll get through their illness. They won't need to be in the hospital. But there are some important signs to look for. For example, if you're at home and around day 5 to 8, which is when many people will start to develop more severe disease, if your oxygen levels are low, or if you find that your shortness of breath is increasing, it's a very important thing to at least reach out to your physician or think about evaluation at an urgent care emergency room, because that can be an indicator of more severe lower respiratory disease. The other thing I'll say is persistent gastrointestinal symptoms. Especially if you can't keep down liquids, you can very quickly get dehydrated with the high fevers, and this is an important thing to keep in consideration, especially around, say, that 5 to 8 day period, which is where people either sort of get better and recover from their disease, or they start to get sicker and may require the hospital. Now, just because we're getting into flu season, let me point out that with influenza, you tend to get fever, GI symptoms, body aches. All of that tends to come at once. However, with COVID, the differentiator is that in general, the fever is independent. The respiratory symptoms then come, and the GI symptoms tend to be later in the disease and actually can be a marker for more severe disease. Now, just to remind you, this has been deadly for so many people. In the US alone, we have 6.5 million cases as of today, and we're approaching 200,000 deaths. So another 961 Americans have lost their life from COVID-19 since yesterday. And as I said, luckily, 80% of that 6.5 million will be either non-symptomatic or mildly symptomatic. But the people we're going to talk about in the next slide or two are those 15 to 20% who end up coming into the hospital with symptoms. About 5% will be sick enough to come to an ICU unit, and the mortality rate goes up as the symptoms increase. So there are risk factors for having to be in the hospital with this virus and for being admitted to the ICU, and ultimately things that are associated with higher mortality rates. The one risk factor that is really emerging across multiple studies is obesity. In younger people, people under 50, severe obesity, so body mass indices or BMIs greater than 35, is actually an independent risk factor for very severe disease. But when all comers, being obese, having a BMI between 30 and 34, almost increases your risk of being hospitalized or being sent to an ICU by almost twofold. And as you get heavier and as you get older, that odds ratio or that chance, the risk of being admitted to the hospital increase. The other problem is diabetes, and this is especially true of people with diabetes who don't have it well controlled. Twofold higher risk of hospitalization or ICU admission, and a higher risk of death in these patients, especially if their diabetes is not well controlled while they're in the hospital. Kidney disease, chronic kidney disease, especially if the COVID-19 is complicated by acute on chronic kidney dysfunction. Kidneys have those ACE2 receptors as well. And in chronic kidney disease, those receptors may be more prominent, more plentiful. So COVID can certainly cause bad kidney disease. And there's over a twofold increased risk for hospitalization with that. Heart disease, low ejection fraction, funny heart rhythms. When you have an indication of cardiac injury, leaking in a protein called troponin, that can increase your risk of hospitalization or death by fourfold. Hypertension is mildly associated with increased risk for hospitalization. And again, it depends on how well controlled your hypertension is. And then age. So clearly, patients over 65 have a higher risk of hospitalization and death. And frankly, patients over 80 have about 20 times the risk of death as patients who are in their 50s, and over 100 times the risk of death of those in their 40s. And then for those who are struggling with cancer, malignancies, especially in active treatment, this immunosuppression certainly increases the risk of hospitalization. And, unfortunately, this disease, it's becoming clear that this disease discriminates along a number of different lines, including age and race and ethnicity, and probably socioeconomic group as well. As you can see, and this is especially true in Southern California, Latino, Black and brown people, Latinos, African Americans have been much more severely affected by COVID, and the death rates are also higher. Again, when you look at the age distribution, mortality is highest in the older age groups. But again, especially in California, we have the 65 to 70 and 50 to 64-year-old population that bears almost half the death rate here. Now, Dr. O'Day mentioned mask wearing. This is what you need to do. Let me just show you this short video.
Stay healthy.
Great.
Stay healthy.
Great. Less loud.
Stay healthy.
Good.
Are you recording?
Yeah.
Stay healthy.
Louder.
Stay healthy.
Louder.
Stay healthy.
Nothing.
So certainly vaccines are some period of time away, 6 to 12 months, I think is a good target. But in the interim, mask wearing, hand hygiene, social distancing have saved multiple lives. And we really encourage you to remember that, especially in the face of the airborne virus. In terms of treatments, I'm not going to go into this much, but there are two treatments that have evidence behind it, so science behind it. Remdesivir, a 5-day course of this medication, does decrease the length of stay in the hospital. And although there was not a statistically significant decrease in mortality, that may be about the number of people that were actually in this study. And certainly there was a 11.9% death rate for placebo versus 7.1% for the drug. The steroid dexamethasone for 10 days or until you get out of the hospital in patients who need oxygen or are on a ventilator definitely has been shown to decrease the all-cause death by about 25%. So we generally use that in our patients that are admitted to the hospital. And as you may have seen yesterday, Eli Lilly, which makes a monoclonal antibody that's very similar to the monoclonal antibody that we are using here at St. John's that Dr. Fisher will talk about, reported that in their initial use of this antibody in patients that were not in the hospital, they were able to decrease hospitalization from 6% to 1.7%. So that's a 72% risk reduction, or in other words, for every 25 people that they treated with their antibody, one person was spared hospitalization and ICU admission. So at least the monoclonal antibodies are giving us hope, but we still require more time to study these. And then, as you will hear, things like convalescent plasma has very little data to support it. We don't generally use it or recommend it. Chloroquine and hydroxychloroquine are not supported, and these are CDC recommendations and NIH recommendations. And even the IL-6 receptors outside of clinical trials are not used. Now, let me just close by saying that evidence is building that COVID-19 affects heart muscle and has long-term effects. And so cardiologists are increasingly following these patients as they recover from their illness. And you don't have to be in the hospital to have these effects. And residual lung dysfunction is also something that we're seeing. This is a nice study that was published looking at the red is the damaged part of the lung. And you can see at the onset of COVID, most of the lung is taken over by red. But as you go 6 weeks post-hospital discharge or 12 weeks post-hospital discharge, there's still significant residual disease. And we anticipate that people who survive COVID will have long-lasting effects. And some of these may be more subtle, like brain fog, fatigue, headache, insomnia, chest pain, joint pain, because COVID really is a multi-organ disease. So again, the theme of today is modify your risk. Until a vaccine is available and until the prevalence of COVID is decreased enough in our community, it's essential that you wear a mask, avoid crowds, especially indoor spaces with poor ventilation, and make sure that you understand your medical conditions and the risk factors that may increase your risk of, if you contract COVID, requiring hospitalization or closer follow-up. And I want to just urge you, because honestly, for every COVID case that we have in the hospital right now, we have 2 or 3 cases in the ICU of chronic medical conditions that might have been ignored a little too long. So don't put off your routine care. We have people that are coming in 3, 4, 5 days after they've developed chest pain and having large heart attacks, people that aren't following their diabetes diet or getting their medications refilled. So I just want to urge you to make sure that you follow through on routine care. That's your best protector against COVID, to stay healthy. And then you can get these slides after the talk, but I put some references for your perusal. So with that, I'm going to stop there.
Thank you, Dr. Hammond. That was a really informative presentation. We're getting some really thoughtful questions coming in, so don't hesitate to plop them in there as we listen to our next two speakers. Next up, we have Dr. Krasny, who will talk about transmission characteristics and testing of the virus, as well as serology testing.
So thank you. Good morning, everyone, or good afternoon, I guess now. So I was asked to talk about serologic testing, and I hope not too many of you tuned in for serologic testing, because I think Dr. O'Day pretty much summarized that, and I will touch on it at the end and give you the essentials for it. But it's really not the most important stuff about this disease right now. So, when I was trying to think of what do I talk about with this group about laboratory testing without boring the heck out of the group, and I heard a story on the news about how important it is that we need to get massive numbers of tests out to doctors' offices, the rapid 15-minute tests to doctors' offices, even to people's homes, so people can test themselves in very quick period of time. And I thought about the pros and cons of that, and that kind of made me think that I think I decided to try to cover some very basic COVID testing principles, so that you listening here now might be able to apply some of your own logic as you consider any sort of testing opportunities or options that are presented to you going forward. And I put a little more than 10 minutes together, so I'm going to skip down to the arrow of my first slide. We're going to skip a little bit. Dr. O'Day did a nice summary of transmission, so I'm going to start with some of the basics. And again, we're starting with some principles that will help you sort of begin to think like a doctor. All right, so the incubation period of basically is the time from contracting or catching the virus to the time of onset of symptoms. And for this disease, as Dr. Hammond said, the average incubation period is about 4 to 5 days. So if one catches the virus, you're exposed to and catch the virus on day 1, on average, you become symptomatic around day 5. Maybe sooner, maybe later, but we're just talking about averages. And one generally becomes infectious about 2 to 3 days after exposure. So say 2 days before symptoms. And then the peak infectious period lasts several days with symptoms, and typically drops off by about a week. Now, there are exceptions to all these numbers, but I'm giving you the typical scenario. And since the infectious period is when the largest amount of virus is present in the upper airways, and thus that virus is able to be breathed out and coughed out, it makes sense that that is also the peak virus detection period, meaning when the lab tests for virus are most likely to be positive. So it may already be apparent to you that the most dangerous time for transmitting this disease is 1 to 2 days before symptom onset, because the patient feels perfectly well, is not sick, is out and about, but is fully infectious and able to spread the virus. Whereas any conscientious person, once symptomatic, would self-isolate and not be out infecting others. And indeed, about 40% of infections are transmitted during this pre-symptomatic period, just a couple of days before symptom onset. So what factors affect the lab's ability to detect this virus? All right, well, the first is the type of test used, and Dr. O'Day summarized there's 2 types of tests. There's tests for the virus itself, and there are tests for antibodies to the virus. And on this slide, we're just going to talk about tests for the virus, which is really by far the most important aspect of testing at this time. So the best, most sensitive test is PCR. Now, there are different PCRs, but they're usually roughly equivalent. And PCR is polymerase chain reaction, but PCR, it amplifies small amounts of virus. So if there's a tiny bit of virus, this technique actually amplifies it, so it's able to detect the virus. And PCR falls under the category, a broader category of what we call NAT tests. And there are some other NAT tests that are not quite as good as PCR. And then there is the newer antigen test. Actually, it's not that new. We've used them for other viral infections like strep throat. They're faster. They call it the 15-minute test. And this is the one that news story kind of perked my interest about how they want to get these antigen tests out for everybody. And you should know the antigen test is less sensitive still than even the worst NAT tests. and will overall miss about 1 in 5 infections that a PCR test would detect. And it's the case that especially in a less infectious scenario, which we'll cover in a second, the antigen test is going to be still more likely to miss an infection. Okay, and then we have the specimen source type. So you should know that in general, the highest yielding source is the nasopharyngeal swab, the NP swab, followed by OP, which is oropharyngeal swab, which is swabbing the back of the throat, followed by swabbing well up inside the nose, what we call the nasal cavity or the turbinate area, followed by the nares or nostril. So these get progressively less efficient at detecting the virus. And then the mouth is most likely to give a falsely negative test. Now, there are some new developments with saliva, which I think is fantastic because it'd be great to not have to stick some implement in someone's head. So saliva is great, especially for children. And some tests are optimized for saliva, and they may be as good as nasopharyngeal, but some are not so good, and they may be inferior. So it can be tricky as a patient not knowing more about the test you're being offered if someone says, take a saliva test. And I'll have to leave that in the interest of time for now. And lastly, it's easiest to detect virus during the peak infectious period, which, as we've covered, is during the early symptom phase. Whereas if you test too early or too late, your test for virus is likely to be falsely negative, even though one has the infection. And there's also a population, as Dr. O'Day mentioned, of individuals who are infected but remain asymptomatic. They never develop the disease, or they may later, but for a long period they do not develop disease. And they too tend to have a lower virus load. Not all of them, but they tend to have, on average, lower viral loads, and they are more likely to test negative using a less sensitive test. And I want to give you a couple of examples now that we have some basic principles, because this is important. So there's a particular somewhat less sensitive NAT test, not quite as good as PCR, but still better than the antigen test that we have here at St. John's. And we have about 5 different tests we use. And during our early investigation with that test, we found that when we were using it on sick, now remember, this is a sort of less than, it's a little less sensitive than PCR, but better than antigen. When we use that test on sick COVID patients in the emergency department using nasopharyngeal swabs, so we were testing high viral load symptomatic patients, we were using the best specimen source, nasopharyngeal. That NAT test was positive in 50 out of 51 PCR patients. So in the ideal testing scenario, a slightly inferior test is comparable to PCR. On the other hand, when we use that same test on a population of asymptomatic residents of a nursing facility using nasal specimens, okay, so we're testing an asymptomatic patient population likely to have lower virus load and using a less ideal collection source, the nose. That same test that was 98% sensitive in the first scenario missed all 6 positive tests by PCR. So a 98% sensitive in the ideal scenario, 0 sensitivity in the suboptimal scenario. And in other words, the utility, and actually this applies to many lab tests, really depends on how you use the test. So now apply that same logic to a situation where you want, say, to clear yourself for a visit to your grandmother or your mother. And you feel perfectly well, and someone is offering you a 15-minute antigen test using a self-collected nasal specimen. So you're looking at using an inferior test, an inferior specimen source, and an asymptomatic person likely to have a lower viral load. And of course, this is a setup to miss an infection. On the other hand, to complicate all this, because I don't have all the answers, there's evidence that an asymptomatic infection, many asymptomatic infections with lower viral loads are not likely to transmit. So maybe you only want to detect a hot pre-symptomatic infection from that standpoint. So one could argue that the inferior test and specimen type is okay in that scenario. I don't have the answer, but I wanted to give you something to think about. Another application of all this, if you think you were exposed to someone with the virus today, would you want to go get tested right away or tomorrow? And the answer, I hope you all realize, is no, because chances are if you caught the infection today, you won't test positive for at least 2 to 3 days, maybe longer. And so best to just isolate yourself and first test at about day 4 or 5. All right, we're going to switch gears now to serology. All right, another kind of test is serology, which looks for antibodies to the virus in one's blood, which if present would indicate previous, most likely recent infection. And in classic medical experience, this suggests one is immune and now safe from the disease. Early on, the first serology tests were point-of-care tests, POC tests. There were these plastic pregnancy-style devices your doctor could just read as positive or negative. And there was such a rapid rush to market. There were over 50 different device makers in the beginning. The devices came out ahead of the technology. None had FDA clearance. Some worked so-so, some didn't work at all. And my advice, even though that some of them do work, my advice is just don't allow yourself to be tested with one of those devices. More recently, much more reliable antibody tests have been developed for the large main laboratory analyzers. Most patients are positive within about 2 weeks from the time of symptom onset. Yet even these still can be positive in people who were not infected. That happens generally about 1 in 200 tests. And what I mean by pretest probability is if your doctor thinks that you had COVID by your symptoms, say a couple weeks ago, at which point one is typically now past the time where a virus test would be positive. Remember, that drops off by about a week. But we know after 2 weeks of symptoms, there's a 98% chance you would have antibodies to COVID. So in this case, a positive serology test almost certainly confirms that you're infected. So because of the high clinical pretest probability, the positive test result is statistically likely to be correct, confirming infection. On the other hand, take a situation where one is just curious and wants an antibody test. I just want to know if I had the infection. In our area, the pretest probability in that situation, no history of COVID illness, is about 1%. And with that low pretest probability, given the frequency of false positive tests with antibodies, even with a good serology test, there's a 1 in 3 chance that that positive test is wrong and you didn't have the infection. Some other limitations of COVID serology tests today, at this point in time, are we don't know which antibodies equate with immunity. We don't know how long immunity lasts. And there are emerging more and more stories, examples of how, and reports of how reinfections are occurring with COVID just within weeks to months of first COVID infection. All right, so when is a serology test indicated? Well, I just gave you that example, and that is in someone who was infected over a week ago, or was sick over a week ago, has typical symptoms, but tests negative for virus now because they've passed their viral detection window. Yet they still may be sick and needing specific treatment. So in that situation, a positive serology test confirms the infection. And really, there's no other reason to get this test now, because skipping to my last bullet point, a positive result does not guarantee you were infected, especially if you haven't had classic COVID clinical illness. It doesn't assure that you are immune. It doesn't assure that you are not infectious. And so there's no action or assurance you can take from a positive test, and a negative test doesn't really mean much either. So I think in time, the serology of COVID will be refined and will hopefully take on a more useful role in the next year or so. But for now, I'd stick with the virus test and hope the pandemic either passes or an efficacious vaccine comes out soon, and I'll stop there.
Thank you so much, Dr. Krasny. Next up, we have Dr. Fisher, who's going to be giving an update on clinical trials.
Well, thanks all for joining, and to my other colleagues who spoke. I always, even though I hear these talks and converse with you guys almost daily about these, I always tend to learn something from you. So I appreciate your expertise in the field, and I'm proud to be part of this team. You may wonder why a surgeon would be giving a talk on this, and I just wanted to disclose that I'm not an infectious disease doctor or pulmonologist or critical care doctor. I'm a surgeon by training, and I was I got involved in this when in March, when we sort of kind of closed down all of our elective surgical cases, and I have some experience in clinical trials through the cancer program here. And got involved and have found this to be very rewarding sort of part of my job that's now sort of continued on. So there's sort of three main areas where clinical trials are ongoing. One is antiviral therapy, which we've spoken about briefly already, and that's remdesivir is sort of the name that we all recognize. And there are numerous different antiviral therapies that are being investigated all throughout the world. The other is immune-based therapies. And so given the fact that this virus can cause an hyperactive immune system, looking for agents that modulate those responses are being explored as adjuvant treatments. And these are typically thought of more for the moderate or critical patients experiencing symptoms from COVID-19. And then there's vaccine therapies, and I'll speak the least about that today, as those are ongoing. We do not have any open trials at the moment, but look to add that to our portfolio in the near future. So just briefly about some of the completed clinical trials, and I wanted to take a second just to give a shout out to our clinical trials teams here. There's a lot of people behind the scenes that are doing some really amazing work and have taken on not only the COVID clinical trials, but they continue to do the other aspects of their job and taking care of cancer patients every day. So I wanted to give a recognition to them as they've really made these trials work here, and to the hospital leadership as well for supporting us doing these trials. So we've several completed trials that we'll discuss. One is one of the trials that I looked at remdesivir. So it's the antiviral medication in patients with severe COVID-19. And this trial specifically looked at whether 5 or 10 days made a difference. And that was the primary objective of this trial. It also looked at the safety and tolerability of remdesivir. And as we all know, many trials are ongoing, looking at different pieces, and with the rapid nature of and changing aspect of this disease, all this data is now coming together to make a more complete picture. So this trial looked at patients who were requiring supplemental oxygen and had evidence of pneumonia, either on X-ray or CT scan. And they were excluded if they had evidence of multi-organ failure, like renal failure, or needing to be on medications to keep their blood pressure up, or if they've been on a ventilator for more than 5 days. They had to have adequate hepatic and renal function as well. So that was one trial that was ongoing that's now closed. The second trial that sort of paralleled that is looking at a more moderate group. And this looked at 3 different groups. One, a 5-day course. Second group would be a 10-day course. And the third group was the placebo group, which would just be getting standard of care treatment at the time. Similar inclusion and exclusion criteria, except these patients were not having any hypoxia from the disease and were greater than 94% on their pulse ox room air at the time of screening. So these trials all went into the EUA access for remdesivir. The first moderate protocol trial, as Dr. Trace mentioned, it did improve symptoms at 11 days. The severe trial looked at the 5 versus 10 and showed similar results, which led to the recommendation of only treating for 5 days. And then this last trial, which we weren't a part of, but really did get the ball rolling with allowing this drug to be used under the emergency use access. The other trial that we completed was an immune modulator trial with sirolimus. It's an IL-6 inhibitor, and as Dr. Hammond mentioned earlier, these drugs, these immune-based therapies can modulate the immune response or damp down that response and help the symptoms and hopefully avoid some of the longer-term complications of this disease. Sirolimus is an IL-6, an interleukin 6 monoclonal antibody that's used in patients with rheumatoid arthritis. And we've noticed that the cytokine profiles, or these inflammatory markers for patients with moderate or severe COVID-19, overlap with some of those patients seen in other syndromes. And so we use those medications in this, and this is where a lot of the oncologists have come in to play a big role because these medications are used in their fields as well. So this trial it was a randomized placebo-controlled trial looking at two different doses of sirolimus and a placebo, and they were stratified by how sick they were. In April of this year, there was some data that came out that the higher dose was important, and the preliminary analysis showed that it did lower some of the inflammatory markers. However, it was ultimately found at this time that this trial did not support the use of IL-6 in itself in any of the severity subgroups, and has sort of fallen out of favor, at least locally, as sort of an upfront therapy for those who are sick. So now I'm going to just move on briefly so we can have some time to get to some of the great questions that I've noticed come through to our open trials. So we have a trial through Novartis. We'll just call it the MAS COVID trial. And this is looking at patients with COVID pneumonia and impaired respiratory function. And this drug is expected to, it's another immune modulator and expected to neutralize these two interleukin receptors, IL-1B and IL-18. And this is, again, just to damp down this inflammatory response. These patients, similar inclusion criteria, have to have elevated inflammatory markers to qualify for the trial. So this trial is currently ongoing, and we're one of about 12 sites across the nation, I believe, that are enrolling patients into this active trial. The next trial, which has been mentioned several times, I think has a lot of buzz in the community, in the medical community as well, is the Regeneron's anti-spike protein antibody. So this is a monoclonal antibody that consists of two fully humanized neutralizing monoclonal antibodies directed at the S protein. And it's thought that this protein is, if we can block that, it will sort of neutralize the effects of the virus. And we have both an inpatient and an outpatient protocol for this, which we're enrolling patients in actively. The outpatient trial sort of looks like this, just to give you guys a brief overview of what the trial is. A one-time dose, so you're in the clinic or in the hospital for a few hours in the morning. You get an infusion, get some swabs, get some blood drawn, and then the rest of it's all done at home. So there'll be a home health nurse that comes to the house and does some of the swabs, checks some of the blood, and then our team will call in periodically and check in. We think that this drug has a lot of potential, and we're very excited to offer it to the community. The last drug trial I wanted to talk about is a combination. So it uses both the antiviral approach and the immune modulation with another IL-6 inhibitor and remdesivir. And so this study is looking at more of the critically ill patients. So you have to be on significant oxygen supplementation and meet several different criteria for enrollment in this. And we think that there may be some utility in IL-6 in specific patients, and this trial is sort of looking at that specifically. And so this gives patients the remdesivir regardless, and the other arm of it is placebo versus tocilizumab, the IL-6 inhibitor. So just real briefly, I think you've met most of us. Dr. Romero is our infectious disease doctor who's out on vacation this week, and a well-deserved vacation for him, and some more of our information. And all this stuff lives on our website. Feel free to reach out to any of us. And with that, we'll turn it back over to Lily, and we'll be happy to take some of your questions.
Thank you so much, Dr. Fisher. We got a slew of questions. We're going to do our best to answer as many as we can with as much thought as we can. We don't want to cut off any good answers. The first one that came in was a question about travel. Is it really safe to travel on planes? If so, should there be a quarantine period once you reach your destination? Dr. O'Day, you want to take that one?
Well, I can make, but Therese and David may want to. So obviously, it's calculated risks, like Dr. Krasny was talking about. Obviously, depending on your own health history and your own vulnerabilities, And then, but when you're in a confined space for an extended amount of time, you're because of the aerosolized nature, although planes are very filtered now, there's some risk. It's not zero, particularly now if everyone's wearing a mask and there's social distancing on the plane, obviously these risks keep going down. But overall, it's not a zero risk. Being in a confined space for hours at a time, there is some risk. Having said all that, I think it's becoming safer, and we will see. But Therese and maybe David, do you have any quick comments on that?
Yes, Steve. I think it sort of goes back to the slide. There are predispositions to getting more severe COVID, and I think that if you are obese, if you do have heart disease, if you do have poorly controlled diabetes, you really need to think hard about taking the kind of risks that flying would entail, especially with the recirculation. I think ventilation systems are still, there's still some concern there. And if you do need to travel, using appropriate, wipes on the seat, wearing a mask, social distancing, all of those things are quite important. But again, I think the predisposing conditions, the pre-existing conditions that might make it should be figured into these choices.
Therese, it comes up with me that eye protection too, particularly on planes. I know in the medical, in our context, we're very mindful of not just our noses and our mouths, but our eyes. Do you recommend traveling on planes to wear goggles or some kind of eye protection in addition to masks?
I had a patient who traveled, and she actually wore one of the face shields for that very reason. She has an immunosuppressive disorder, and so really wanted to be careful. So there are some shields that you can wear. But yes, this is an airborne virus, so that's, I think, a conceivable way that it can get into the body. Although remember, it's about not just the virus, but it's also about the dosing that you get exposed to. So these things like masks and shields can maybe not prevent you from getting in contact with the virus, but hopefully will prevent you from getting a big enough load to get sick with it. Like that video showed, with and without masks, it makes a big difference.
Just one comment on the shield on the airplane. The shield doesn't help you at all from aerosolized virus. It's only for droplet spray. So it really doesn't really have any role on an airplane unless...
Except if someone coughed directly on you, right? Or something.
Of course.
Right.
Yeah, exactly. So,
yeah, thanks for the clarification.
Yeah, that's great.
Awesome. Thank you for that answer. The next question that we have is someone asking, can you get COVID-19 more than once?
Yeah, we already know. We're seeing reports of that. We have examples of it. It tends to be less severe the second time. Maybe Therese or Steve, you may have more experience directly, but I have seen reports and we've had patients.
I think Therese you may know more than I do about that. Other than there are reports rarely that this happens.
Yes, we actually did have a patient who was treated at an outside hospital, hospitalized for 8 days with COVID, was in the ICU, was on a ventilator for a short period of time, was discharged from the outside hospital, then approximately 5.5 to 6 weeks later, came back in with COVID, very severe, was transferred to our institution for ECMO support, and sadly died of COVID. So we personally have seen this. It's not entirely clear if it's a new infection or if it's an infection that just doesn't go away. But I think I think that all of that is in need of study.
And one more thing about lab testing on this, we have seen much more common than like a real clinical reinfection. We've seen patients who have had COVID who will test positive 2 months later, continue to test positive 6 weeks, 8 weeks later. And they tend to be asymptomatic, and we don't really know what's going on there. We think there may be non-infectious viral particles, viral RNA, but so a positive test many weeks after clinical illness does not generally mean reinfection.
Yeah, and would it be, and a question for you, David, would it be correct to say that we really are still struggling to know what, and for Steve as well, what what having antibodies to COVID really means, how long it lasts. Is it a forever or a long-term protection, or do antibodies fade over a period of time?
Yeah, we don't know. I don't think we know yet.
Just one quick comment on that. We are partnering with the NIH on some of these patients to have specimens sent to them for full analysis to see if indeed this shedding phenomenon versus a secondary infection have come up. So it's another sort of opportunity that we provide here.
And I would just say the antibodies, represent one arm of the immune system called the B cells. But actually your primary, and that's more important for bacterial infections, but your primary defense against viruses, of course, are T cells. And we haven't seen a lot of data on T cells have memory and the ability to protect after the initial virus. So having these antibodies that Dave's talking about may or may not protect against reinfection. It really will depend on, is there T cell memory? And we're going to get a lot more. And we are working with NIH and others around the world with our samples to help that. You've seen very little data in the news around T cell response, which is your primary antiviral response. And even with the vaccines, the paucity of data on T cell responses has been alarming. And there's two reasons. One, it may not be being done routinely, or it may not be showing as much benefit. So let's be very cautious about that. Yeah.
Wonderful answers. Great insight. We've got time for about two more questions. I do want to know we might go a little bit over. One other question that came in was that, do you recommend getting the vaccine when it's first available, or wait until later when more side effects have been discovered and testing has been done?
Tress or
Well, I was gonna zing that one at you, Steve, but
okay.
I will comment by saying that science is absolutely essential here, and we have to make sure that any vaccine that's released and given to large numbers of people is properly evaluated through scientific studies.
Yeah, I think that's a hard question to answer right now. I think all of us in the scientific community, as you've heard, are quite concerned about the politics of this and the timing. The bottom line is we need more time to both establish safety and, most importantly, is it working? And it's a complex assessment of whether a vaccine's working. Is it preventing new infections? Is it just minimizing the severity of infection? These are endpoints that are going to take time, particularly if the prevalence of the disease where the vaccinations are happening are low, because you have to wait to see. It's much better done in very high prevalent populations, and it's been a moving target. So we will need to fully vet the vaccine data. And I think what you're hearing from the scientific community is we need integrity around this process, and we need to rigorously look at this data. But if the data is there for safety and efficacy, then I very much hope anyone who potentially benefits from the vaccine will take it, so that we can develop the herd immunity that's really going to allow us to get back to a highly functioning society.
I'd just like to throw something in there that's outside of my expertise. I do know that it's not uncommon for internists who recommend vaccines. When a vaccine is new, they like to wait 6 months to a year to let large numbers of people get the vaccine and see what the real side effects are. Because often when a new vaccine comes out, we still don't know yet all the side effects.
Yeah, and I just wanted to add two things. One, there are, I think at this point, something like 12 to 15 vaccines with different mechanisms of action. So the first vaccine that's released may not be the best vaccine, but we have to do science to figure that out. And then the second thing is, as you saw, a large number of the patients who are being affected by COVID are Latino or African American. We have to make sure that trials are include a broad swath of America, so that anything that we test can have applicability across all socioeconomic and ethnic groups.
So as we're waiting for the vaccine and letting the scientists digest the information and the follow-up that is necessary to establish benefit and safety, let's do what we know it works. And that is what we talked about at the beginning. It's a matter of social distancing, wearing masks, washing your hands, and assuming others have the virus so that you can protect yourself and others. And it's also about getting, with early symptoms, there's opportunities to get intervention short of vaccine right now with our spike antibodies, which may be the next really pivotal part of this. And know that if you do get sick, you have an institution like St. John's and Providence that we really built a state-of-the-art team around us that can give you the absolute best care and make clinical trials with cutting-edge new approaches available to you. And we're here to be ready to stand by and help you and your loved ones. So reach out to us, but most importantly, be safe and spread the word about the facts as we know them now. And we know a lot about the facts of this virus right now.
Thank you so much, speakers. This was a fantastic webinar, and we're really excited that everybody could join us today. If you have any questions or comments about today's webinar, please don't hesitate to contact us. The information is on our screen. Tune in next Thursday for our prostate cancer webinar at 12 p.m. Pacific time. Registration can be found on our website. We appreciate your time, and we hope you have a great day. Thank you.